Today we're going to talk about heparin-induced thrombocytopenia from a cardiopulmonary bypass perspective. Specifically, we're going to talk about HIT, and heparin-induced thrombocytopenia, or HIT, is a prothrombotic donor mediated by platelet-activating antibodies that target complexes of platelet factor 4 and heparin. So let's break that down a little bit. We know what heparin is. It's the anticoagulant molecule. It's a heterogeneous family of glycosaminoglycans. Thrombocytopenia is a condition in which you have a low blood platelet count. So we have a heparin-induced low blood platelet count. And it produces a prothrombotic disorder. Prothrombotic, a condition that leads to thrombosis, mediated by platelet-activating antibodies. Antibodies are produced in response to and counteracting a specific antigen. And so what is that antigen? It is the complexes of platelet factor 4 and heparin. What is platelet factor 4? It's a small cytokine that's released from the alpha granules of platelets. And so if you look inside a platelet, one of its components that is inside a platelet is called an alpha granule. And inside the alpha granula, there's these cytokines and chemokines like platelet factor 4 that can be released when the platelet is activated. So this is an immunological phenomenon caused by the use of heparin. And of course, for us perfusionists, heparin is a very, very important drug. Arguably the most important drug we use for cardiopulmonary bypass to prevent the blood from clotting in our circuits. So let's look at heparin as a way of review. It was discovered by a medical student at Johns Hopkins, Dr. McLean. By 1935 there was some human trials, and by 1939 it was approved by the FDA. So it's been around for 80 years. Again, the structure of heparin is very heterogeneous. It is a negatively charged molecule, and it can bind to a variety of plasma proteins, not just not just antithrombin. It has multiple effects on many, many plasma proteins. But if you look, the molecular weight is variable, very heterogeneous, unfractionated heparin. Molecular weights from 3,000 to 30,000 Daltons. Heparin has some really great characteristics, but it is synthesized endogenously. We all make our own heparin. It's stored in basophilic granules of mast cells, high concentrations in the lungs and intestines. And the way the sources that we have historically used to get to produce and to manufacture heparin have been from pig intestine and cow lung. Neither renal nor hepatic dysfunction has any significant effect on heparin elimination. So some of the characteristics of heparin in its natural state. Of course, we know the primary action of heparin as an anticoagulant is that it binds reversibly to the naturally circulating antithrombin 3, and that activation is pretty profound. It accelerates its effect by 1,000 to 4,000 fold. However, heparin has no effect on pre-existing thrombus. It is not a fibrinolytic or a thrombolytic. It will not break down clot directly. It'll just prevent it from being formed. We love it in bypass. It happens so quickly. Within 3 minutes after our bolus of heparin, we get a response. And so it's very, very effective, and it's very effective quickly. And it's very highly effective at preventing thrombosis of cardiopulmonary bypass circuits if we keep that ACT greater than 480 seconds. The other thing that's really great about heparin is we can monitor it very simply and rapidly. We can monitor the activated clotting times, and we can measure heparin levels. And that's very important. A subject of a later lecture on alternate anticoagulants shows that monitoring those other anticoagulants is very difficult and time-consuming and not quite as simple. The other nice thing about heparin is it's easily and rapidly neutralized by protamine. That's not without risks. There are protamine reactions, but it is easily and rapidly neutralized. We can give protamine, and really within minutes we have restored the hemostatic balance and our ACTs have gone back to normal. There are drawbacks. Heparin has a variable response among patients. We don't all respond the same to heparin. And again, as we spoke about, neutralization can be dangerous in a protamine reaction. There are categories of protamine reactions that can be life-threatening and require reinitiation of bypass. And then, the subject of today's lecture, there is HIT, the heparin-induced thrombocytopenia. And if you add another T on there, heparin-induced thrombocytopenia and thrombosis, then we're looking at a very significant and serious complication that can be life-threatening to our patients. So again, heparin does a lot of things. It interacts with platelets. It does have an immune and a non-immune response. Heparin and inflammation and malignancy. So heparin is not one of these drugs that just has a very specific point. We look at it as an anticoagulant, but it has many other effects on different blood proteins. So we talked about sources of heparin. We talked about porcine intestine or beef lung or cow lung. And we've pretty much seen a removal of the bovine lung heparin preparations. A couple of reasons: mad cow disease, and also there have been studies that show that that the beef source has a higher incidence of heparin-induced thrombocytopenia. Not sure exactly why, but the bovine lung, the studies show HIT ranging from 1.9 to 30.8%, whereas porcine gut heparin 1.3 to 8%. So it appears that using the porcine source we automatically get a reduction of HIT. So again, unfractionated heparin is the drug most associated with heparin-induced thrombocytopenia. Can be also lesser so with low molecular weight heparin, but we still see incidences of HIT with that. And then there's other highly sulfonated polysaccharides that can cause HIT. But again, unfractionated heparin is where you see the most association with heparin-induced thrombocytopenia, which is bad for us when we use the heart-lung machine. So let's talk about it a little bit. Again, for the last 80 years, heparin has been widely used as an anticoagulant drug for the treatment and prevention of thromboembolic disorders, and that includes the emergence of cardiopulmonary bypass. We, since that first case in 1953 by Dr. John Gibbon, cardiopulmonary bypass has become a staple of cardiac surgery, and heparin is the ideal drug of choice to anticoagulate the patient for these procedures. Some terminology: there are two types of HIT. The one we are most interested in is HIT type 2, and that is the immune response and the reaction that we're going to talk about, the pathophysiology of HIT type 2. There's a non-immune heparin-associated thrombocytopenia. It's also been, you might also see it in the charts as HAT, heparin-associated thrombocytopenia. And type 1 denotes the absence of heparin-dependent antibodies and the potential role of other factors causing the thrombocytopenia. HIT type 1 is less of an issue for us as perfusionists. That doesn't scare us. We will go ahead and use heparin on those patients. It's the HIT type 2 patient that we really need to pay attention to and to understand before we do any kind of anticoagulation with heparin. So you can see the frequency of these these events is variable. Fortunately, HIT type 2, the one that we're most concerned about, is fairly low. The timing of onset, and that is for thrombocytopenia, you'll see a profound drop in platelets within 5 to 10 days of exposure to heparin. It is antibody mediated, and the thromboembolic sequelae, 30 to 80%, is very high. So we have a very high risk of HIT, H-I-T-T, heparin-induced thrombosis, and heparin-induced thrombocytopenia and thrombosis. So again, HIT type 1, we're not afraid of those cases. Heparin should be continued if it's still indicated. You don't present an additional risk of thrombosis there. But let's talk about type 2. And let's first look at the pathophysiology of this. And it is a clinico-pathological syndrome. Clinical because we have thrombocytopenia and or thrombosis. These are clinical indicators, clinical signs. And it's pathological in that it's heparin-dependent platelet-activating IgG antibodies. So you have that immunological pathology associated with this disorder. And this is a really important slide, so let's take it slow, digest this. I want you to understand this. So heparin interacts with platelets. It's a mild activation, but it does cause the release of these chemokines, that PF4, that platelet factor 4 we talked about. So heparin will interface with the platelet and mildly activate it, releasing platelet factors 4. Now, PF4 and heparin can form an antigen complex, which induces the formation of an antibody against it. Here's our classical Y-shaped IgG antibodies, and the antibody is formed against this antigen complex of heparin and PF4. So once those antibodies are there, now the patient will react to the presence of heparin. So the sequence, the antibodies will bind to the FC2A gamma receptors on the platelet surface membrane. This binding causes strong platelet activation and the release of microparticles. And these microparticles are intensely procoagulant. They really promote the formation of thrombin. These HIT antibodies also can bind to the endogenous PF4 endothelial heparan sulfate complexes on the vessel itself, on the endothelium, and that can also trigger thrombin generation. So it works in a couple of different ways, but it's that release of microparticles that can really cause a cascading of thrombosis. So again, we're in a bind if we have a patient that has these antibodies and can potentially react this way to heparin administration, because nearly all the patients undergoing bypass are exposed to heparin. It's a little difficult to actually diagnose the level and the susceptibility of HIT, because most patients do have postoperative platelet count that goes down. So we're always somewhat suspicious of HIT in the population that we have given heparin to. Fortunately, the incidence of HIT in cardiac surgery patients who receive intraoperative and postoperative unfractionated heparin is lower than the incidence of suspected HIT. So we suspect HIT a lot more than there is actually HIT present, and that's about 1 to 2%. So let's talk about how we diagnose it. And we're going to look at the diagnostic procedure in two main categories. There are, well, in two main broad categories. There's the clinical diagnosis, then there's the laboratory diagnosis. Let's talk about the clinical diagnosis of HIT. And it's the 4 T's that have emerged as our way that we can clinically diagnose. And it's the timing of the platelet count fall, thrombocytopenia, the level of low platelet count, if there is thrombosis or other sequelae, and then the fourth T is the other causes of thrombocytopenia. And they have actually a point system here. If the platelet, the timing that you'd get 2 points if you had a clear onset between days 5 and 14. That's the typical platelet fall in patients that have HIT. Thrombocytopenia, if it falls greater than 50%, so you actually quantify that drop in platelet count. Thrombosis, if there's new thrombosis or skin necrosis at heparin injection sites, or if there's an anaphylactoid reaction after an IV heparin bolus, all of these things would factor in. If you rule out all other causes of thrombocytopenia, that adds more points. So with the 4 T's, you can have 8 points, and if you have 6 to 8 points, a total score of 6 to 8 points is considered a high probability of HIT. So again, it can be a little fuzzy on the clinical diagnosis. Does a patient really have HIT? Can we really categorize these as a HIT type 2 patient? And so there has to be the laboratory diagnosis as well. And there's 2 main categories of laboratory diagnosis. There's an immunological test, and there's functional assays of platelets that we can use. Now, in the immunological category, there are immunoassays which will detect that anti-platelet factor 4 heparin antibody, and it just can detect the antibody itself. It doesn't say that they're activating platelets or causes HIT. The nice thing about this test, it's widely available and it's very sensitive, but it is associated with limited specificity. So again, it's highly sensitive with low specificity. That could produce a lot of false positives. Then there's the functional assay, which detects only those antibodies that have the capacity to activate platelets in a heparin-dependent manner. And these are, on the plus side, they're very, very highly specific for HIT. On the negative side, they're complex and expensive and time-consuming to perform. Some of these things are like the serotonin release assay of platelets. So the bottom line here is we have a clinical way to diagnose HIT, and we have these 2 laboratory diagnoses. The bottom line in the diagnosis is if immunoassay testing must be coupled with careful clinical assessment, and a positive immunoassay test should be confirmed with a functional assay that also confirms the diagnosis. It's really important to get the diagnosis right, because if you have to delay surgery or have to use an alternate anticoagulant, it can really cause some significant complications and may impact patient care. So what do we do for bypass? What's the ramifications when the surgeon calls you and say, hey, I have a HIT type 2 patient that I want to do surgery on? Well, one of the first things you need to do is try to determine what phase is the patient in with HIT. Are they in the acute phase, a subacute A, subacute B, or a remote phase of HIT? So let's dig into that. So if you're a patient in the acute phase, will exhibit the following. They will have a decreased platelet count. They'll be in a thrombocytopenic state. They will have a positive functional assay and a positive immunoassay for HIT. The subacute, the platelet count may have recovered, but they still have a functional assay and an immunoassay that are positive for HIT. In both of these cases, if at all possible, you should delay surgery. The antibodies persist, are transient. They usually will go down to 0 within 3 months. So if you can delay surgery, that's the thing to do. If surgery cannot be delayed, then we have to consider using an alternate anticoagulant like bivalirudin or agatroban, and we'll talk about the alternate anticoagulants in another lecture. But if you can't delay surgery, you've got to either use an alternate anticoagulant or treat the patient with preoperative plasma exchange until the functional assay becomes negative. So neither one of those are great options. The alternate anticoagulants are always very difficult because they don't have those advantages. It's hard to measure the level of anticoagulation with these alternates, and it's hard to reverse as well. And so it gets pretty tricky. Now, if we look at that subacute B category, where their platelet count is recovered, they have a negative functional assay, but they have a positive immunoassay. So you still can detect some of those antibodies, but those antibodies don't seem to be triggering any kind of reaction from the platelets. Again, if you can, delay surgery. Let's not take the chance. But if you got to use surgery, let's do it. Let's use surgery and go ahead. Based on that functional assay, based on that platelet count being down, let's go ahead and use heparin. Now, if this is a patient that is in the remote phase of the history of HIT, their platelet count's recovered, their functional assay is negative, their immunoassay is negative, you just plow ahead and use heparin on those cases. So this is a very tricky patient population, but with careful diagnosis, with understanding the course of the history of HIT in the patient, good decisions can be made. It's always good to have a protocol, whatever hospital you're at, especially if you're going to use the alternate anticoagulants. Both surgery, anesthesia, and perfusion all need to be on the same page with that. Thank you, guys. Hope you're doing well out there, and look forward to talking to you soon. Bye-bye.